Welcome back, guys. Now we will discuss calcifying epithelial odontogenic tumor in a continuation of our series of odontogenic tumors. So we had discussed ameloblastoma in last lecture. So what happened before 1955? C.E.O.T was famous as was known as a variant of ameloblastoma with calcification. Right. It was believed to be, or you can say the other names for that was calcifying ameloblastoma or adenoid ameloblastoma or cystic complex odontoma because of its very peculiar calcification features. But after 1955, sorry, in 1955, it was Pinberg who termed it as a separate tumor, who actually termed it as calcifying epithelial odontogenic tumor. That's why it is also known as Pinberg tumor. It's a very rare tumor, very rare. It's just 1% of all odontogenic tumors. This tumor originate initially it was believed like from Pinberg. He said this tumor was originate from REE, which is reduced enamel epithelium. But later, Chaudhary and his companions they discovered tumors with REE origin. Now we'll discuss the clinical features. This tumor, it's just 1% of all odontogenic tumors. We know that, right? It's just most common in 3 to 6th decade of life. It is equally prevalent in males as well as female, but the chances of occurrence is more in mandible, like you can see twice that of mandible in twice that of maxilla. Right? It's usually grow as slow growing as when we dissect it, you know, when you dissect the tumor, you can actually see calcific remnant. There are two variants of it. Most common is central regions, basically intraosseous lesions, and around 1 to 2% of that there are chances of peripheral, basically known as extraosseous lesions. Radiographically, these lesion appears as radiolucent to radio opaque. It's have a very distinct radio opacity feature. That's why it is known as calcifying because there is central tendency of radiolution. There are three phases. Initial lesion, as it grow and become a large lesion. In starting phase, it's mostly radiolucent. Later, it become a mix of opaque, radio opaque to radiolucent, and in later stages become pure radio opaque. The very prominent, very beautiful appearance of radio opacity is known as driven snow appearance. As you can see, the tumor within mandible, there is ill-defined margins. You can see, right? This is driven snow appearance. This is how pinbug tumor appear in CBCT. You can see the amount of calcification. As it grow, it become more calcified. You can see a mix of radiolucent and radio opacity. Right? Histologically, this tumor appear a variant kind of ameloblastoma, very mixed match features. That's why it's usually believed to be ameloblastoma. In this, you will find islands, sheets, or strands of polyhedral epithelium cells. And where do you see polyhedral epithelium cell? Stratum reticulum. Stratum reticulum in enamel organ, right? It consists of very distinct variation in nucleus, which are giant. Some cells show polymorphism, some do not. The very distinct feature histologically is there are areas of amorphous eosinophilic extracellular material. And which material is this? Which material show amorphous eosinophilic material, extracellular material? It's amyloid. Yes, it will react to Congo red. How do we diagnose amyloid? Amyloidosis, how do we see it? With Congo red staining. Congo red staining, right? But what happens? This amyloid, it's sometimes, like most of the times, it just become calcified from lamina-like structure, and this structure, calcification of amyloid material, leads to the formation of very beautiful ledge gang rings. This is important. This is the diagnostic feature of C.E.O.T. As you can see, these are ledge gang rings, right? These are ledge gang rings. These are all ledge gang rings. In this, you will even find some clear cells also. The another feature is presence of clear cells also, right? These are the histological features. How do we treat it? Treatment is very simple. Either surgical excision, right? Or if the tumor is very large, we can resect the mandible or the maxilla. Hemisection. In this, what we do? Resection of part of maxilla or mandible is done in very large lesions. And if after hemisection, after large resection, we have to rehabilitate the jaw by either plates or reconstruction plates or bone grafts. Now the differential diagnosis. The very first differential diagnosis is ameloblastoma. It is differential diagnosis to radiolucent lesions. If you see radiopacity, it's C.E.O.T. If it is radiolucent, the chances it is going to be ameloblastoma. What are other? Regional odontodysplasia. When there is presence of enamelodentin, the chances it going to be in a regional odontodysplasia. In C.E.O.T, you won't find enamelodentin in C.E.O.T, but in regional odontodysplasia, you will find enamelodentin. Antigenesis or occasion or myxomas. For these, I told you difference between cyst and tumor. I told you in neuroblastoma also It's all about the growth. If it's like, for example, this is your jaw, this is your cortical plate, this is your cortical plate. If your lesion is growing like this, it's a cystic lesion. If your lesion is growing like this and it is robbing your bone, its chances it's going to be a tumor. That's a difference between dangerous cyst and OKC. With this, I sum up with C.E.O.T. We will meet again in next lecture. Good day.